FM with me, Nortey by nature. Welcome aboard. Humbled and honored to have you. Yeah, last week I had the Platinum family in the house. Yeah, I've gone up the road a bit, into Tema. Today I have the Sinel family in the house. Our old friend Dr. Michael McCarthy is here. I have alongside him in studio Dr. Theophilus Thompson. He's a medical officer with Sinel Specialist Hospital, Specialist and Family Hospital. And joining us kind of like around hour, we'll have Dr. Mary Monibote. She's a specialist urologist specializing in surgery. We're looking at prostate health and screening. I know many times when you hear prostate, then you start thinking of cancer. Well, today we'll distinguish and differentiate for our discerning listeners. If you have any questions, concerns, WhatsApp is 055 11 11 997. We're live on Facebook and YouTube. And as usual, I will activate the phone line so you can ask the questions yourself. Ultimate Health on Joy 99.7 FM. Docs, good afternoon. I can hardly hear my guests. Abeku, have I done something wrong with my mics? Hang on a sec. Yeah. Good afternoon, Docs.
Good afternoon.
See,
Good afternoon.
Abeku was playing tricks with me. But great to have you.
Nice to be here.
Dr. McCarthy.
Yes.
We should we should just start paying some rent and have you here full time.
Full time, you see. That would be really nice.
Yeah, but it's always great to have you. And many of my listeners who know you are a consultant obstetrician gynecologist will wonder, well, why is Michael here? We know he does stuff with the women. We know he's the CEO of Sinel Specialist Hospital. What are you doing here?
Yeah, somebody sent me a message and said, "Hey, have you moved from the women to the men?" And they were scared.
So what's the link?
No,
just to help our listeners. I know the link.
Yes. I mean, I see a lot of women, and I know behind every woman there are a number of men in various capacities and categories.
When you put it that way, you say because you're an obstetrician gynecologist. When you say behind every woman, there are a number of men.
Yes, there are husbands, there are fathers, there are uncles, there are brothers and cousins, there are sons, and it's interesting to see the link and how it goes.
Right.
And we know generally that men are not very eager, to show sign of weakness and come to the hospital and say, "I'm not well, there's something not going right," and so on.
Okay.
And so we decided to put something in place to see how we can encourage men to get checked. And for men, the important thing that is running through is really having to do with the prostate and related issue.
Okay.
So that's a big background, but maybe later on I'll share some more deeper and personal backgrounds to why this.
Right. So, my listeners, the men, you are part of the Stubborn Academy. Even when you discern subjectively things going wrong with your body, you are very, very, very reluctant. All right? Sometimes even the men don't like me using this. You are afraid.
Wow.
Let's put it there. You are afraid, you are reluctant, and it kind of maybe diminishes your own sense of masculinity to go in there and say, and the women do it better. Let me put it that way. All right? Relatively more likely to present with health-related issues, symptoms, concerns than men. All right? So today we're swinging to the side of the men. We're looking at prostate health. I know some of you say prostrate. It is prostate, the prostate gland. And we're going to go through with my gentleman in the studio. Yeah. And it's interesting. Most obstetrician gynecologists are men, like Michael's dad. And my dad and Michael's dad both passed on, right? But we also have, who'll be joining us on Zoom, Dr. Mary Monibote, and she's a urologist, right? And many people say, well, we don't get women swinging that way either, but we'll explain why we have her here. She's fully qualified and ready to, educate, inform, and transform. But initially, let me come to you, Theo. Dr. Thompson.
Yes, please.
Right. I guess my listeners would want to kick off and get some understanding of what the prostate is and why we should be concerned about it, men and women alike.
Yeah. Very rightly, like you said, usually when we hear about the prostate, everybody is talking about prostate cancer.
Mm-hmm.
But that is just one of the many things that happen to the prostate.
All right.
There could be inflammation of the prostate just like any other tissue in the body.
Okay.
There could be increase in the growth of cells, which we will talk about in detail on this meeting. That's the benign prostatic hyperplasia.
Okay.
And all what we know is the prostate cancer.
Mm-hmm.
So sometimes, you hear people saying, if it causes problems all over the, why don't you just take it out? Why don't we just take the prostate out?
Mm-hmm.
But the prostate actually has a function in the body.
Right.
It produces some fluid actually that help in the vitality of the sperms.
Okay.
So the semen that comes out actually has a portion that is secreted by the prostate gland.
Okay.
So it's not just all about diseases. It also has its own important function in the body.
It's normal function.
Yeah.
Right.
Yeah.
Manufacturers, should I say, software.
Yeah, software.
Has put this up there to do certain things, right?
Yeah.
And you're explaining what it does
Yeah.
in the normal, healthy male.
Yeah.
Okay.
Yeah. But just like everything in the body, it's also susceptible to certain pathologies.
Mm-hmm.
So as we grow, usually with the men, there's an increase in the number of cells that make up the prostate.
Okay.
Now, usually in every tissue, there's a balance between cell death and cell creation.
Okay.
But as you grow for the prostate, sometimes the cells seem to multiply more than they die.
Okay.
Now, when this happens, it causes a change in some of the things that the prostate does, and then leads to some pathologies. So when we talk about
say pathology, I know I've got discerning listeners, and they are googling as you speak per word, right? But just break it down. So it means there's something wrong.
There's something wrong
with the gland,
with the gland itself.
Okay,
yes,
the prostate gland.
Yes.
Okay,
and the prostate gland is just found also just around the urethra, which is the passageway of urine.
Okay.
So usually people with all urinary problems usually will point to the prostate as being the cause of the problems.
Causal factor.
Yeah. And what's interesting is that it's made up of various structures that I wouldn't bore your listeners with.
Okay.
But what's important is the part of the prostate just around the urethra is where it's likely to have the increase in the cell growth, or what is called the benign prostatic hyperplasia.
Okay. Let me slow you down a bit. Folks, if you've just joined us, we're moving like a high-speed train, but that's because sometimes when we possess all the information, we speed a bit. But I have the speed gun and the speed camera. So I'm going to slow it down a bit, right? Yeah. We're talking about prostate health, right? This is a gland that males have. I read somewhere that females have some equivalent of it, but it doesn't do these kinds of things. We're talking about the male prostate, right?
Yeah.
And Dr. Thompson is explaining that it has its function. It secretes certain things into the semen, which enhance the health, the vitality of the male sperm, right? So it has clear functions, positive functions. Yeah. But like any other organ or system in the body, it can go wrong, right? And he's identified one of those things that can go wrong as the benign prostatic hyperplasia, okay? Benign means it is not cancerous, but it's still a problem, okay? And he's talking about growth of cells. Growth of cells. And I'm going to come back to him, but I'm reminding you that WhatsApp is 055 11 11 997. We're live on Facebook and YouTube, and shortly we'll activate the phone lines as well. We will shortly also be joined by Dr. Mary Money Borte, a urologist. Yes, I see her on my screen, but I'm told she's working out, preparing for you. So she'll join us around 1:30. All right? Okay. But since she's here, maybe let me just say hello, Dr. Borte. Good afternoon.
Yes. Good afternoon. How are you?
I'm fine, thanks. Great to have you on the show, although remotely.
Yes.
Okay, but we'll join you or we'll bring you in shortly to maybe brush up on some of the things we're sharing to our listeners through or via Dr. Thompson in the studio. So, Doc, so what you said was that the cells can grow normally,
Yeah.
which means that some cells will be dying,
Yeah.
and some new cells will come into the system. All right?
Yeah.
Okay, some kind of balance between load shedding and. Let me not go there. All right? Okay, let me not go there. All right? So, in benign prostatic hyperplasia,
Yeah.
and we are confessing the, should I say, emphasis that seems to immediately or automatically go onto prostate cancer, right? We've established this one is not a cancer, but it's also a growth of cells.
Yeah.
So in the cancer, we are having growth which is abnormal.
Abnormal.
Growth of abnormal cells.
Yes.
And this, I guess, correct me if I'm wrong, is growth of normal cells.
Yes. So for the benign prostatic hyperplasia, that's normal cells.
Okay.
Yes. Just that the amount of application is less than the amount of the cells dying off.
Okay.
But with cancer, yes, it's abnormal cells.
Okie dokie.
Yeah.
Right? So benign means there's a growth, there's an enlargement in the prostate gland,
Yeah.
but it is not cancer.
Yes.
And I guess, it's important to be able to make that diagnosis and that distinction.
Yes. Very, very, very important.
Okie dokie. I hope you've understood that. So we've understood that.
Yeah.
Our prostate gland can become enlarged,
Yeah.
right? And
Yeah.
that has its own problems it causes.
Yeah.
And we should be mindful of these problems.
Yeah.
We're not saying because it's not cancerous, it's not a big deal.
Yes.
Okay. And I guess also that because you are adding it to our discussion on screening, you want our listeners also to understand that screening is not just about cancer.
Yes. Definitely.
Right?
Yes.
Yeah?
Very, very important.
Not just about cancer.
Yeah.
There may be something wrong with your prostate, but it may not be cancer, but it still needs a good looking at
Yes.
and some form of intervention or management.
Yeah.
Okay, great stuff. Right. Anything else you want to add by way of
Yeah.
introducing us to BPH?
Yeah. So we just with like any other problems in the body, just like with even carcinoma of the prostate, breast cancer, there are certain factors that will make one likely to have benign prostatic hyperplasia.
Risk factors.
Risk factors.
Risk factors.
Risk
Okay.
factors. Now I
It's
see
almost like
this-
saying who is vulnerable.
who is vulnerable.
Who's at risk.
Yes.
Okay, great.
So it's actually once you are a male, you are already at risk.
Okay.
Because this the hormone that actually keeps the prostate growing is testosterone, and every man has it. So as you are growing in age, yes, the prostate is going to get bigger, but the transition in whether it will just get big without any symptoms to you,
All right.
or it will get big and cause some certain kind of problems, also depends on some certain things like your race,
All right.
some certain things, maybe what you are eating.
Your diet?
You've had other things too as well, which is a little bit controversial as to whether sex can actually affect the prostate.
Okay.
For the purposes of this discussion, we are not going to talk about that.
All right. So when it comes to race, what is the vulnerability, or what's the
Yes.
risk variable?
So we over here have a higher chance of developing benign prostatic hyperplasia.
Okay.
Yes, but when it comes to the carcinoma, it's quite difficult to say either here or there.
Okay.
But with the benign prostatic hyperplasia, we usually will have a more higher number of people.
When you
having
say
it, yeah.
we, just
you mean the Africans?
Africans are
Yes.
more likely,
more
predisposed to develop
yes,
benign
prostatic hyperplasia.
Okay. Right. Is there any reason? My listeners are very, very keen on these things because they go and bully people after they listen to Ultimate Health. They say, "Wait, we have their you don't know anything.
Yeah.
Listen to us. We listen to Nortey and his guests, and they said this." Is there a reason why it's more likely?
No, reason wise, no, but it's just that it's been found more.
Okay.
Just like the number of people who present with that are more here
All right.
than there.
Maybe I'll bring in Dr. Bote.
Yeah.
Doc, if you can hear me.
Yes, I can hear you.
Right. I'm missing the feminine touch in the studio. So I had to bring you in, right? Not on the cosmetic level, but more on the qualified professional level. You are a urologist, right?
Yes, I am.
Okay, and you specialize in surgery as well.
Yes.
So you go
I
down
agree.
there and do the plumbing and all that for the men.
Yes, I do.
Yes, you do. Okay. Let me ask, by way of, building rapport with you. I mean, a female urologist. How many of you are there tinkering with us down there? Are there
We have
many women
two.
in urology?
We have 2, and one is in training now. So there's a third one in training.
Right. So I'm lucky to have you.
Very lucky.
Pleasure is mine.
And my listeners are lucky to have you, right? Okay. I've done Ultimate Health for 20-something years. I do not think I recall having a female urologist. So I am very, very chuffed and very proud of myself. But coming to the point I just left with Dr. Thompson, the race issue. I did some too known tinkering and reading, and I heard part of it has to do with diet. Is that right? That the Western diet is less fiber and more fat, or something like that? Is it part of
Not
it?
necessarily. Not necessarily.
Okay.
Studies found that it's patients of African descent.
Mm-hmm.
So even if you go to the Western world, the Africans there, the African Americans, have a slightly higher propensity to have prostate enlargement compared to their Caucasian counterparts, even though they may have the same diet. It's more genetic.
More genetic. Okay. So there's a genetic predisposition to BPH, right?
Yes.
Okay.
And even prostate cancer.
All right. With prostate cancer, it also plays out?
Yes, it does.
It does. Okay.
Yes.
All right. Is there anything you want to add with the foundation I built with Dr. Thompson in the studio? Anything you want to add?
Oh, he's building his point. Let him get there.
Okay. All right.
He said almost all the important points so far that need to be said.
Okay, great stuff. It's about 26 minutes past the hour of 2 on Joy 99.7 FM. We're looking at prostate health and prostate screening. When you're screening, essentially you're looking out for signs and symptoms, telltale indicators and flags of a disease, of a condition, initially in presumed to be okay people, and then you follow up on what you yield from the screening. But we'll try and get a deeper understanding of what we're looking for when we talk about prostate screening. Dr. McCarthy, let me bring you back in. I know you've sent me this online questionnaire. You are over 40. In fact, you are over 40. Mm-hmm. And is that part of a screening campaign that you are very earnestly prosecuting at CINEL?
Yes, Nortey, last year we started this screening campaign for men, and it was just awesome. We got quite a number of people signing up, and the whole idea was we want to see the men and see how we can conscientize them towards health.
Okay.
And so they sign up, we see them, and we note so many additional things.
Right.
It's not just about prostate and erection and sperm production and so on. There are other things that are going on with the men, and when they come in, they more easily open up and say, yes, I also have this issue, I also have that issue. Dr. Thompson saw a lot of those patients, and it was really useful for the men because for once we're able to focus on them in a non-judgmental and very light environment, so that they could actually we could actually pick out some of the problems and point it out to them, and then have those discussions.
Right. When you say the men, did you say registered or logged
sign
on?
Up.
Sign up.
So they sign up.
What exactly do you mean? Do I come to CINEL? Do I write my name? Do I say I'm a prostate converted something? I mean, what's the process? And why is it that you seem to be reporting after about a year that you have a very commendable response from males who typically would not enter into some of these?
Yeah, I mean, some of the men would come back with their brothers. Some of them will come back with their fathers.
Okay.
And out of this, we actually diagnosed a number of prostate cancers.
Okay.
Which nobody knew were there. Mm-hmm. So the gentleman comes, he's screened, he has a good interaction, and he says, hey, my dad needs to have this as well. He brings his dad, and suddenly different things come up,
Right.
Some just in the nick of time, some maybe not as timely as we would have hoped. And so we said this year we're going to do this again. We just send out a simple a form that people can fill and ask for a slot for screening.
Right.
You don't need to fill the form. You can just walk into Sinel Specialist Hospital. You could call us, you could Google us online, and we'll be very happy to just offer that screening to you.
All right. So let me get it straight. So if I go online, I Google Sinel Specialist Hospital, right? Is there something which says prostate screening form or prostate data, prostate info? What am I looking for? And then what again do you want from me once I click? Are you going to ask me all sorts of intimate things?
No, we just need to know whether you want to come in or not. That's all.
Also, it's like almost like booking for a screening.
Yeah. You just say I want to come, and we say yes. When do you want to come?
All right. So
we do it during the week only. During the week from Monday to Friday during working hours. Right. That's when we do it. But for a few people, we've had to do some special timings for them if they wanted to. Yeah, we did.
Okay, so men are being encouraged to come in for prostate screening.
Yes.
Right?
Yes.
That is not to say so you don't need to have symptoms.
No, you don't need to have symptoms.
Please hit that one because that's the part I want to particularly emphasize. You don't need, this is a screening, and I've said screening essentially is checking for signs of problems in people who may or may not have signs, right? And then you can cut it down, cut to chase, and then you can arrive at something conclusive. So people or men do not need to have symptoms or problems, right? So the same way we looked at risk factors, is there anything that should indicate to Nortey or anybody else listening, especially male, that says this is for you?
Yes, so this is for you if you are male between 40 and 70.
Mm-hmm.
Just tell us you want to come and see us, and we'll see you. It takes an hour. We run a lab test, we do an ultrasound scan. You meet with the doctor, and that's it. If you find anything else, we push you on. When we started this,
just the 40 and 70.
Yeah, 40 and 70. When we started this, however, then the guys under 40 started complaining that why are we not doing something for them? So we have a program for the under 40s as well, to also check them. And then we've also done a program for those who have problems with passing urine, those who have prolonged catheters inserted and so on, who can also come so that we can see how we can assist them.
Hit me properly on that. I want to be swinging to Dr. Botte about now, but hit me. Why 40 to 70? If I'm 72, right, and I have some problems, or I don't have problems, but I'm anxious, I want to know, am I debarred from coming to bother you and your team?
No, not at all. Not at all. Right. We just.
Is it a critical age range?
It's the critical age range that we wanted to just pick out and focus on. But just like those under 40, we see them as well.
Okay.
And then definitely we see people who are above 70. Those who brought in their dads were above 80. And we'd love to see them.
So what it is that you've got a big cohort or samples of men who have come in. And my understanding is this is essentially voluntary.
It is voluntary.
They've come in. They are not coming. Are they coming with referrals from other places?
No referrals. No referrals. Just come in. I pick it from the gynecological point where we see women once a year, talk with them and find out what's going on and make their life better. And we say, hey, we need to do this for the men as well.
All right, great.
It's been awesome.
All right, 32 minutes past the hour of 2 on Joy 99.7 FM. You're listening to Ultimate Health, your ultimate guide to healthy living, which includes the health of your prostate, right? I'm in the studio with Dr. Michael McCarthy, consultant obstetrician, gynecologist, and I guess the head honcho, Chief Igwe, and Chief Servant at Sinel Specialist and Family Hospital, TEMA. Is it Community 6? No.
6, yes.
Yes, Community 6. Yeah. I'm not that old. Yeah. 6. They are here not just particularly to talk about themselves and their services, but to educate, inform, and transform. Today, we are looking at prostate health, prostate screening, and also shedding more light on the less talked about BPH, benign prostatic hyperplasia. A lot of brothel, but we'll break it down. Right? If you want to break it down yourself and ask questions, WhatsApp is 055 11 11 997. We're live on Facebook and YouTube. Right? And shortly I will activate the phone lines, but not after I've properly welcomed Dr. Botte, urologist. Doc, I'm back to you.
Yeah. Thank you.
Right. So we did give some distinction between malignant cancerous prostate enlargement, right? And therefore prostate cancer. And then this one we're talking about now, benign prostatic hyperplasia, where there's an enlargement of the prostate, but it is not cancerous.
Yes.
Okie dokie. My listeners be wondering, well, are there differences? Because many of us, as soon as we hear prostate, Charlie, it's cancer. As soon as we hear downstream problems with urine shedding, not load shedding, then we know prostate. So can you help us with an explanation, hopefully a distinction, which is really your remit, but we want listeners to know of its existence and why we are concerned about BPH.
Okay, so with benign prostatic hyperplasia, like Dr. Thompson explained earlier, it's overgrowth of normal tissues with an imbalance of the breakdown, death of those cells. Normally in the human body, there's a balance between new tissues being laid down and old ones dying off. But in this case, they don't die fast enough. So then they become large in the prostates.
So
and they can
excess capacity. Go ahead.
So it's the problems they lead to that is why we are having this talk.
Okay.
So you may see men come in with all sorts of symptoms that we call lower urinary tract symptoms. And that is important to find out. Some people may even have these symptoms and they don't know.
Okay.
Some people think that when I go and stand at the washroom and it takes me like a few seconds before the pee starts coming, oh, that's normal, which is not. That's what we call hesitancy.
Right.
It all has to do with the changes in the prostate that may be ongoing. And so some people may pee more often than normal. Every few minutes, they have to use the washroom.
Okay.
That's called frequency of urination. And that is as a result
of
frequency.
I'm hitting frequency, right? You're peeing a lot, right? And then hesitancy is that the urine is stammering, right?
Yeah.
Right? So it's coming, but it's not coming some way. That is hesitancy, right?
Yes, it takes a while to start coming. And when it starts coming, sometimes it stops. And then a few seconds later, it continues, stops and continues. That is intermittency.
Okay.
All these are, we call them lower urinary tract symptoms.
Okay.
That point towards the prostate.
Okay.
So some people may have this. Some people will say, I'm peeing a little more often. But they say, oh, I drink water a lot more. When you find about the other symptoms, then it you can point out that, it's because they have some prostatic symptoms. That's why they pee a lot more often. And even at night, more importantly.
Right.
At night, if you are getting up more than 3 to 4 times at night, you have nocturia.
Right.
It's
Please go ahead.
So then you need to go and seek help from your doctor.
Okie dokie.
We try to pick these things up and then judge them. We have what we call an international prostate symptom score index.
Okie dokie.
So with these symptoms that you have, like frequency, and then there's another one called urgency. When you have to go, you have to go.
Pressure.
Some people, you can't wait. If you wait, you pee on yourself, and that's so you have urge incontinence. So all these symptoms are put together, and they are usually as a result of the prostate enlargement that these patients present with. Okay. And until you take a history from them, it's difficult to find out that they have these. Some may come in and say, I've been peeing too much. Some usually they come, my sleep is disturbed. That's usually what the patients will complain of. So you usually come from them. And we need to address these issues before they lead to other complications, like acute retention of urine.
All right.
Where the pee it's not coming. Okay, I guess I'm getting ahead of myself.
Right. So folks, 39 minutes past of 2 on Joy 99.7 FM. We're learning about prostate health, what it's supposed to do, and how that can malfunction. Right? We've zeroed in on benign prostatic hyperplasia. Right? There's growth, all right, but that growth is not cancerous growth. But it still presents with problems. You just heard Dr. Nortey, a urologist, sharing some of the downstream symptoms or problems. Urine hesitancy, urgency, the pressure to urinate or empty the bladder, and then hesitancy, and then the other one was urgency. Intermittent. Yeah. Okay. Right. Basically, the urine is not flowing the way it should. Right. And note also that the prostate is between your bladder and it's at the neck of the urethra. So when it becomes enlarged, it can also narrow, I believe, the urethra. So that's why you have the urinary symptoms.
Yeah.
Okie dokie. Doc Nortey, please. We've mentioned that if there's an imbalance between the death and the birth of cells, we can have this. Is that the only thing? It sounds pretty normal that could probably happen, but is there something causing this imbalance? And are there other causes of this BPH?
Usually that is the main pathophysiology of the BPH.
Okay.
Nothing, and it's usually commoner in patients above 40.
Right.
So not specific to the rate is what differs from person to person.
Okay.
So you have somebody who is about, let's say, 45 or 50 years old, and his prostate gland is likely maybe 50 or 60 grams.
Okay.
By the way, the normal weight is 20 grams. Right. So 50 or 60 grams. And you may have a 70-year-old whose prostate size is also 50 or 60. So you realize that this person's gland the younger person's gland is growing faster. And those are just differences in between patients. The important thing to note here is the symptoms they cause.
Okay.
Because it's not always that the size is responsible for the symptoms.
Okay.
Someone have a prostate gland of about 70 grams and may not have any of the symptoms I've just outlined.
Right.
Someone's gland is just about 40 grams or 35 and may have all these symptoms.
Right.
So it has to do with the smooth muscles being laid and then the restriction they cause to the outflow.
Okay. Right.
Of the
great stuff. 42 minutes past your hour on Joy 99.7 FM. The program is still Ultimate Health, your ultimate guide to healthy living with me, Nortey by nature. I am just flooded. There's no hesitancy on the part of my guests. They are flowing, right? We're talking about prostate health and screening, and we've zoomed in on the less often talked about benign prostatic hyperplasia. I'm enjoying, pronouncing it. It makes me sound very knowledgeable. But that's why I brought them into the studio. If you have any questions, concerns, WhatsApp is 055 11 11 997. We're live on Facebook and YouTube. Let me announce the phone lines as well. 030-221 6541. 030-221 6541. Those are the healthy buttons to push to get in directly with these learned professionals. Right. This says, please, I forgot to add my name or add this. My father has prostate cancer and he's in his 70s. I'm not quite relating. There's something above. Noted. Good afternoon. My name is Kwesi from Kade. I checked my PSA last year, September 2023, and my PSA figure was 1.6 ng/ml. I am 43 years. Should I be concerned about this figure? What can I do to reduce the figure? All right. He's talking about the prostate-specific antigen test. We'll probably get to that. We have promised to extend this into next week, so we'll talk about that. And then he adds to this that his father has prostate cancer, okay? And he's in his 70s. He is 43. His father is in his 70s. So he's giving us some family history as well. This one says, "Hi, Nortey. I just tuned in and heard the male doctor finish speaking. Can you please mention the name of the hospital and the telephone number so I can visit to screen for my prostate?" No, it's not missing. You screen the prostate itself and its health, right? He's 52. Thank you, Kweku in Akropong Ekwepim, right? He wants the digits for Senil, all right? Thanks for sharing. Okay, he's a willing person. What about people? This is from Dede in Maryland. Is 40 not too late? That's your cutoff. What about people with family history? Should you not be going lower down for people like that? That is from Dede. Hang on to the questions. I'll come back for responses. This one says, "Good afternoon, Nortey. How are you and your invited doctors? Thank you for your good work done. Now, my question is that at what age is prostate cancer treated?" Not treated, sorry. Okay, yeah, I missed that. I looked at Michael because he was smiling and I missed the not, right? At what age, this is Hayford in Bato, what age is prostate cancer not treated? Probably he's heard of some people being told they are under observation and so on and so forth, right? Mm-hmm. So second, who is most at risk to get prostate cancer? Already the crawl and the creep and the shift to prostate cancer is coming in, right? We're not there yet, okay? We're not there yet, but I know why it's, playing out this way, right? This one says, so Dede has asked about those with history and whether this is not too late, a cutoff 40 years. Hayford is asking, is there a point where you don't treat or you advise not to treat prostate cancer, though we're not focusing, we're not there yet at the cancer. We're looking at the benign form. All right. So those are the questions. This one says, "Good afternoon, Nortey and your wonderful medical doctors. Please, are there any good habits or lifestyle practices that one can follow to improve our prostate health?" This is from Fred in Community 24. Fred, you're close to Senil, or no, 24 is out there a bit, but
very close.
Yeah, but it's close. Yeah. All right. Okie dokie. Somebody says I say okie dokie a lot. It means I'm happy with what I'm doing. This one back from Dede is the correlation between one's dad having family history, prostate cancer, and the probability of his daughter, right, having breast cancer exceptionally high.
Some link.
Is there any truth in this? So she's suggesting a link between your father having prostate cancer and his daughter being a likely candidate for breast cancer. Dede is asking that. And Dede's questions are very, essay-like. They are not multiple choice. Yes, no things. All right, Dede, thanks for sharing that. So, Doc, let me go back to Doc Bote on Zoom to take some of these, right? Right, Doc. Hayford in Bato is asking, is there a stage or an age where prostate cancer, he's talking about cancer, is not treated? And then Dede in Maryland is asking about this cutoff of 40 to 70, saying the 40 might be too late, though we're initially or essentially talking about BPH. Everybody's bringing in the cancer as well. So if we're screening, is 40 too late? And is there a point in time where we might not be wanting or might not wish to treat prostate cancer?
Okay, thanks. These are some of the problems that come up with screening. So prostate cancer screening is not sort of universally worldwide. There are various schools of thought.
Okay.
American Association of Urologists and all that. There's every region has its ideologies to go with that. The reason why is that screening for prostate cancer, you may pick up what we call clinically insignificant disease.
Okay.
And then you over-treating and over-diagnosing and leading to over-treating. The reason why I'm saying this, prostate cancer is quite extensive. It's mainly a disease of men above 65 plus. And so above that age group, and it's a slow-growing disease. Right. Now, if you make it so that everybody is screening, now somebody who is 75 years old, who otherwise may have had a very slow-growing indolent cancer, now picks it up and goes through the gamut of treatment, which may lead to more complications from the treatment, as opposed to leaving the patient and do what we call active surveillance or watchful waiting.
That's what I was looking for.
Screening usually is important for those who have a higher risk of the disease.
Right. So
mainly those with a first-degree relative family history. That is your father or your brother.
Okay.
Because the risk is higher in these. It's been found that if your grandfather or your second-degree uncle has it, you may not be as likely to get it as someone whose father or brother has it.
All right.
And so we focus on that. And for those who have a higher risk, smoking within 10 years of maybe you may be symptomatic or not. So, however, we also understand that because prostate cancer it can be deadly, people won't sit down and then say, oh, let me wait till maybe I'm above 65. So people are self-screening, like what we are talking about currently. Right. And so that's why then we said, okay, then let's put it at 40. Because at 40, that is the stage where the prostate is rapidly dividing. And cancer is formed in rapidly dividing cells. You are more likely to get the disease when rapidly dividing cells there. That's why we said, okay, then let's start at age 40 then. And even then, it's usually in those with the higher risk.
Okay.
Somebody about, can't we go lower?
Especially if there's family history.
Yes. We have special cases where even now talks are going on in the urologic community that to go lower, because we've had 38-year-olds who present with prostate cancer. And you'll be like, oh, if we had picked it up earlier, the patient. And usually another thing too is when prostate cancer you get it below age 65, it's usually the aggressive form.
Right.
So you are more likely to do it at that age.
Okay.
Someone asked about when would you not treat prostate cancer? It's because of that I went into this screening and all that.
Okay.
And so you will not treat prostate cancer if the life expectancy of the person is less than 10 years. So you an 84, 85-year-old come in, symptomatic of BPH, you do the PSA is high, and then the person has prostate cancer, early disease. Then you take the patient through rigorous treatment, which can involve radiotherapy with all the attendant side effects, or surgery, radical prostatectomy for these patients. And then the patient rather dies from your treatment modalities. You haven't helped the person. However, someone at age 60 who has the disease already has it's assumed that the person has a longer life expectancy than 10 years. So you would go. So at age 85, if the person is not symptomatic of the disease, we can offer the person what we call watchful waiting or active surveillance.
Okay. All right.
You see, so those are the distinctions we made. And also, if somebody bedridden, has the CVA, has bed sores, has all other things going on, despite the age being less than 83, 84, there's no business taking the person through this rigorous treatment modalities for prostate cancer.
And I guess all of these will be explained to the patient or the client.
Yes.
All right. It's not as if we just say go home, we won't treat you. All these modalities, considerations will be properly explained. So
Indeed,
that you don't go home and tell them, I have that thing. They say they won't help me. Ghanaians will say, yes, it's not that. It is. It's not that. A lot of considerations go into this. Can you quickly, Doc, if you may, talk about the gentleman who is 43 and says his PSA, he gave us his PSA
1.65,
right? And he's asking if he should be worried. His father is in his 70s and has prostate cancer. I know that PSA is not the only marker, and there are other reasons why your PSA may be elevated. What would you say to this gentleman?
Yes, so with his father is in his 70s. Like I explained, prostate cancer is a disease of elderly men. His father may not be the typical familial type of the disease.
Okay.
So his risk may not correspond to his father having prostate cancer.
Right. It's not automatic.
However, it's not automatic. However, if his dad got the disease before age 70, then by all means, I'd want to follow him up.
Okay.
Like we said, the PSA being high can be as a result of other things. So in such a patient, you may have a prostatic infection that may let the PSA go up. So I'll come in, then I'll give you antibiotics for like 2 weeks, targeted at the prostate, and then repeat the PSA for you. If it's still high and the father had the disease before age 70, then we'll do a digital rectal exam. Sometimes you may have a normal looking PSA, but when you do the DRE, it's abnormal, where you feel hard nodules on the prostate.
Right.
Because the various pathological forms of the cancer may present differently.
Okay.
The most common is adenocarcinoma, but you may have some neuroendocrine tumors or whatever that may have normal PSA, but it's cancer.
Okay.
So you do the DRE in conjunction with your PSA. His PSA of 1.65. I will repeat it for him. For his age, his average PSA should be around 0.7. So 1.65, I'll also be a little worried. But then we'll go through all these things. Give him antibiotics. If we repeat it and it's gone down, then we know it wasn't due to a cancer.
Okay.
If still we are not convinced, there's something we call multiparametric MRI of the prostate. It will be able to pinpoint any areas of the prostate that have any lesion that is suspicious. The radiologist will point them out. And then, importantly, you can go and target those lesions if it's found and biopsy them. Because the catch here is that prostate cancer is curable when picked up early.
Right.
That's the whole reason why we are doing all these screen, all those things. So it's quite important.
Thank you, Doc Bote. She was just doing testing mic because next week I'm told, I've been promised that I'll have a live. I shall capture and retain her and detain her, and I'll do my own examination. But Doc, we're most grateful for your input. There's a lot that should go into this. I'll come back to the gents in the studio whilst looking forward to having you next week. It's another way, when I do this on air, then it's difficult for you to disappear. You see, it's called psychological bondage. This is not ritual servitude. It's not strokosi, but you come and live with me small. All right. Many thanks, Dr. Mary Money Bote. She's a urologist and how would I say that? She specializes in urology, but she's a surgeon.
Urologists are surgeons. All urologists are surgeons.
All right, okay. Surgeons, but if a neurologist, then you have a neurosurgeon, right?
Yeah.
Yeah. We don't.
Yeah.
It's different.
I wanted to baptize you neurosurgeon, but it doesn't work. But yeah, okay. Doc, just quickly as we wrap up. So we want men to screen. Yeah. We have been nudged in the direction of prostate cancer. We will get there. right? But with the BPH, okay, we're having men with downstream urinary symptoms, hesitancy, all those things. The stream is not the same. We know there are consequences when urine is held or retained in the bladder for too long.
Yeah.
Right? So there's a higher tendency of sexually transmitted infections or UTIs and many other things. So there are reasons we are concerned. All right? Somebody earlier on wanted to know if there's a contact number. Should they just go online and check this, or would you want to give out any details for those who want to join and be screened?
Yes. So for screening, you can just go onto our website, and our numbers are there. Okay. You can also
website is
sinelhospital.com.
Okay.
You can also make a call to 02477324448 02477324448.
Okay.
And just you don't need to call them. You just need to send a message of your name, and we will then get back to you and put you on the screening list.
Okay.
And then we'll get a date.
All right.
Yes. So
okay.
basically that's
how to come in. Somebody's asking, can BPH cause erectile dysfunction? Can it be treated, and how long? Chief from Boma, right? We'll get into treatment and management of BPH. Do you want to say a word, Theo, on whether it can cause ED?
Yeah. So usually not directly, but sometimes the management of BPH, and even when it's, getting to the point of prostate cancer, can actually be a problem.
Okay.
Yes, and when we do the surgical management, you would find out that one of the complications of the surgery is possible erectile dysfunction.
Okay, okay. The gentleman who gave us his details and his PSA scores, who is 43, says his father had his prostate cancer starting in his 60s.
Yeah.
Okay. I think Dr. Bote has done justice to your kindly shared details. Do kindly also approach Sinel or any other facility and have yourself properly checked, and an analysis of your presentations properly done.
Yep.
Then you can be advised. That's the gentleman. And many thanks for adding more detail. And I'm seeing that the men are sharing on WhatsApp, and they're asking questions. That's good. We're on a good trail here. So next week we'll have our guests back in. We'll break down BPH. Yes, there is treatment and management for it. Dr. Bote will be in the studio with us to go into detail, and then I dare say we will get to prostate cancer, right? Yeah. Don't go saying your thing is not cancer by word of mouth. Do not declare and decree just because you've heard BPH. All of these are well based on proper professional, qualified professional assessment, evaluation, testing. You heard MRI and other things, imaging, there's ultrasound, many other things come in, right? And even a whole urine analysis. There's so many things done. Yeah. So please, I plead with you, as they will say in the Bible, I beseech that you do not, on the basis of this program, say that your symptoms are not malignant or otherwise, or they are automatically declared to be benign because you listen to Ultimate Health. We have the professionals who bring them in to educate you, and that's the only way we know to impact your life, your health, and your well-being. Many thanks, Dr. Michael McCarthy, Dr. Theo Thompson, right?
Yes.
And Dr. Bote, all of whom are practicing at the Sinel Specialist and Family Hospital in Tema Community 6. You can get prostate screening anywhere else, okay? We want to, and I grab them to give the information. It's not tied to their facility or their services at all. Once again, many thanks to my producer, Abeku Kofi. If I didn't get to read your WhatsApp, what he typically does is to forward them to me, and I factor them into the next program. And I do also forward some of them directly to my guests. So don't worry if I didn't get to read your messages. I think we're done, Abeku, aren't we? Yeah? All right. And the gentleman who shared his details, we'll see how best we can bridge with him as well. Stick and stay on Joy 99.7 FM. My name is Nortey by nature. I'm out.